I'm pleased to have with me Dr. Emily Tonorezos, the director of the National Cancer Institute's Office of Cancer Survivorship. In 1995, NCCS published Imperatives for Quality Cancer Care, an influential publication that represented a new approach to defining quality cancer care from the patient perspective. A few years ago, I interviewed Dr. Julia Rowland, former director of the office and now a member of NCCS board, about the creation of the office. She said that Ellen Stovall, NCCS former CEO, boldly took the imperatives report to then director of the National Cancer Institute, Dr. Richard Klausner, and said, "Rick, I think you need to read this." Julia told me that he took it on a long flight, read the document, and when he came back, he didn't even stop go at his own institute. He went to Congress and said, "I'm creating this Office of Cancer Survivorship, because we need answers and we need you to be supporting the science that's going to provide us with the information about what happens to people after cancer treatment." Dr. Tonorezos joined the Institute as director in September 2020, following Dr. Deborah Mayer, this year's Stovall Award winner, who served as interim director. Dr. Tonorezos came to NCI from Memorial Sloan Kettering Cancer Center and the Weill Cornell Medical College, where she served as director of the Adult Long-Term Follow-Up Program for survivors of childhood and young adult cancers. Her research focuses on cardiometabolic consequences of cancer therapy, childhood and young adult cancer survivorship, diet and nutrition, and care coordination. Dr. Tonorezos is a general internist, having earned her medical degree from the University of Rochester School of Medicine and master's in public health from the Johns Hopkins Bloomberg School of Public Health. Thank you so much for joining us, and I'm going to turn it over to you to talk a little bit about the 25 years.
Thank you so much for having me. And I can't tell you what a year it's been, a little more than a year now since I joined the office, and about that amount of time since I kind of gave you my introduction to myself and my background. And it's really my pleasure to be here today as part of the roundtable to talk about the history of the office and what's happened over the last 25 years, and also what I really think we need to be doing next. So let me go ahead, start the show. Thank you again for having me. So my name's Emily Tonorezos, and I am director of the Office of Cancer Survivorship. And I thought it would be great, as we talk about the 25th anniversary, to actually go back even before the founding of the office, when Dan D'Angio, who was at the time a pediatric radiation oncologist at Memorial Sloan Kettering, wrote this amazing paper called "Cure is Not Enough." And the bulk of the paper is a review of childhood cancer treatment and the progress and successes that had been made up until that point in childhood cancer. But what he wrote in that paper is, it is clear that the child cured of cancer must be followed for life, not so much because late recurrence of disease is feared, as to permit early detection of the delayed consequences of radio and chemotherapy. And it was 10 years after that paper that Fitzhugh Mullen wrote his paper in the New England Journal of Medicine, where he said, despite success on the treatment front, we have done very little in a concerted and well-planned fashion to investigate and address the problems of survivors. It is as if we have invented sophisticated techniques to save people from drowning, but once they have been pulled from the water, we leave them on the dock to cough and sputter on their own, in the belief that we have done all we can. Those are really big words. So as you've all seen this graph many times before, but as you know, cancer survivors are growing in number. So we have the words of Dan D'Angio and Fitzhugh Mullen from even 10 years before the office was founded. But this recognition of the growing population of cancer survivors was happening even at that time. And as Shelley mentioned, when Ellen went to Rick Stovall with that report, the end result was actually not what is photographed here, but what happened the same day as this photograph, which is the adoption of the Office of Cancer Survivorship, What you see in this photograph is actually Bill Clinton signing the yellow ribbon of hope. And after this ceremony, he went out into the Rose Garden and announced that he was commissioning the Office of Cancer Survivorship. And what he said at the time was that the office was created in recognition of the large number of individuals surviving cancer for long periods of time and their unique and poorly understood needs. So these are the goals of the Office of Cancer Survivorship. Number one is to support survivorship researchers. Number two, to build infrastructure. Number three, to leverage expertise. Number four, to generate collaborations. And number five, to promote understudied research areas. And I just want to point out something that Shelley mentioned, and that I think is a very important part of the work of this office, which is to say that we always need to be responding in survivorship to what is happening in cancer diagnosis, treatment, and supportive care. And most remarkably to me, over the past few years has been this growing population of people who are living with cancer. This graph shows estimates of the number of women in the United States who are living with metastatic breast cancer, but we see these same sorts of projections and estimates for other types of metastatic and advanced cancer survivors. And this is a population, and I really want to call on the people listening to this talk, advocates, researchers, we are going to have to fight to have survivorship research for this population. And if there is anything that we have learned over the past, I would say even 46 years, if we go back to Dr. D'Angio's paper, it's that there is never a given when it comes to advocating for survivorship research, but we must respond to what is being accomplished in cancer diagnosis, treatment, and supportive care. And this is where I really see the next set of battles for this office and for you guys who are listening to the talk. I want to tell you what we're using as our definition for the population of the survivor living with cancer. So we are calling them those who are diagnosed with metastatic or advanced cancer, or with cancer that has progressed from early stage disease to metastatic. And survivors in this population could be on or off treatment. And the goal of care is to prolong life without the expectation of cure. Of course, this population fits right into the longstanding definition that we have all had of who is a cancer survivor. And I have the benefit of the work of Deb Mayer and others who came right before me, of being able to use this updated definition of the cancer survivor. So it's always been an individual who's diagnosed with cancer from the time of diagnosis and through the balance of life. But what we added was to specifically say that survivors include those living with cancer and those free of cancer. Okay, so let me go back after my passionate plea, let me go back a little bit to talk a little more about the Office of Cancer Survivorship. So as we mentioned, the office was formed in 1996, and very soon after that, Anna Meadows, who at the time was the acting director of the office, and others put out this request for applications on long-term cancer survivors. And the idea was to support research that would examine and describe the health consequences of cancer and its treatment among long-term survivors, which was defined as those surviving 5 years beyond diagnosis. I will just take this opportunity to point out that although it seems like a million years ago, that actually calling a survivor a person who has been diagnosed with cancer from the time of diagnosis was actually a highly debated issue at the time. And there was a lot of discussion about whether you should not be considered a survivor until you're done with treatment, or maybe you shouldn't be considered a survivor until you reach some milestone in your journey, which is to say maybe for some cancers, it would be 3 years after treatment. For some cancers, it would be based on your prognosis. And I really think what the NCCS and the office adopted at the time with this definition of defining cancer survivors from the moment of diagnosis, it was really revolutionary, not just for the people, not just for the survivors, but also for the researchers. Because trying to figure out when someone is done with treatment is actually a huge challenge. And so to try to estimate survivors who are done with treatment or still on treatment is really difficult and complicated. And so by defining a cancer survivor from the moment of diagnosis, what they did was not just make it not just benefit the advocate and survivor community, but benefit the research community as well. And so everything that has happened since that time has been with the understanding that we're talking about people who've been diagnosed with cancer, their caregivers, their family members, and that is the focus of the research. And we talk about survivors who are on or off treatment, who are long-term survivors, who are closer to the time of diagnosis, but they're all included in that umbrella. And it's really meaningful that we do that. I will also say, and I didn't mean to talk on this timeline slide for so long, but I will also say that the term survivor does not resonate with every person. And I think for that group who is living with cancer, it's one of the most challenging places to grapple with that word. And so I just want to acknowledge, first of all, the word survivorship is in the title of the office. It's there, we live with it. I just want to acknowledge that not every person who's had a diagnosis of cancer identifies with the term survivor. And I really think that that's okay, because we're using the term in a research sense, which is to say you don't have to identify as a survivor to be counted as one when it comes to the research. Okay, so moving on just for a second. So over those first few years of the office, there was this funding announcement, there was a first major research conference, and then of course, Dr. Julia Rowland became the first full-time director of the office. And by the time we got to 2001, over 100 grants were funded by the OCS since 1998, which is when they started funding grants as part of the Division of Cancer Control and Population Sciences. In 2002, the first biennial Cancer Survivorship Research Conference was held. And you'll see this theme, but research conferences are so critical for this field, where you have investigators from all different backgrounds and all different educations and approaches. And it's really, really critical to bring people together, because we don't necessarily otherwise meet. In 2004, the Children's Oncology Group published its first set of guidelines for long-term follow-up of survivors of childhood cancer. In 2004, we also hit the $100 million milestone in cumulative funding. In 2005, the landmark report From Cancer Patient to Cancer Survivor, Lost in Transition, was published. And this Institute of Medicine report provided so much impetus and background for many research studies and papers that came afterwards. And it's referenced in nearly every survivorship grant and article that has come out since then. And in 2007, we got our own journal, the Journal of Cancer Survivorship. In 2013, Janet DeMoore and others published the prevalence of cancer survivors in the United States. In 2016, that figure that I showed you before of the prevalence trajectories and comorbidity burden among older cancer survivors, that figure that I showed you before came from this paper on the silver tsunami. In 2016, Congress passed the 21st Century Cures Act, which is also known as the Moonshot. And in 2017, Larissa Nekledoff and others looked back at that Lost in Transition report and delineated where we had made progress, where in the Institute of Medicine recommendations we had achieved some progress, and where we still had work to do. In 2016, we also have this portfolio analysis of survivorship grants. And these are the gaps that were identified. So the paper was actually published in 2019, but I just want to point out at what at the time was found to be missing from the research portfolio of funded grants from the National Cancer Institute on survivors. So there was a call for more longer-term survivors who had been more than 5 years from diagnosis, cancers other than breast cancer, older cancer survivors, more diverse survivors, including racial, ethnic minorities, geographic diversity, and LGBTQ+, long-term and late effects of newer therapies, intervention studies, biological mechanisms and genetic factors for recurrence and adverse effects, and patterns and quality of survivorship care. And then in 2019, Deb Mayer hosted this survivorship research meeting, which I've mentioned here before. So this meeting occurred in April of 2019, and it was an opportunity for researchers, survivors, advocates, and representatives from professional organizations to come together at Shady Grove in Maryland. It seems like a million years ago, but it was just over 2 years ago, to discuss the gaps in survivorship research. There was a subsequent webinar for the larger scientific community, and there was a paper that was published in the JNCI. And these were the recommendations from that paper, from that meeting. There were a whole list of recommendations, but these are the ones that were cross-cutting. So these went across content areas, and so there were many more recommendations in that paper, but I just wanted to highlight these cross-cutting recommendations. Number one, understanding and eliminating disparities. Number two, conducting longitudinal and long-term follow-up studies. Number three, leveraging existing data resources. And number four, incorporating implementation science strategies. So you may see some things in these cross-cutting recommendations that sound a lot like what was in that 2016 paper as well. As Shelley mentioned, my clinical background is as a general internist, and I care for adult survivors of childhood cancer. And so childhood cancer survivors are a population of particular interest for me. I will also say we have benefited in the field from a lot of attention on this population over the last 5 years, most remarkably from the STAR Act. And there were 3 reports which were commissioned by the NCI with STAR Act funding from AHRQ. These were on transitions, so meaning the child who's going from pediatric-oriented to adult-oriented care. Number 2, care models that include primary care providers. And number 3, disparities and barriers to care for childhood cancer survivors. So these are the 3 reports. The last one actually came out first. And this is kind of a complicated figure, but what I want to show you is what is missing here. So this figure is study design, care domain, and primary target of evaluated strategies regarding barriers to survivorship care for childhood cancer survivors. So across this figure, you see a study design, the care domain, the primary target of the intervention, and the outcomes by domain. And I just want to point out that there have been a fair number of studies. Nowhere are there lots of studies, but there have been a fair number of studies that address patient and provider knowledge in trying to improve survivorship care for childhood cancer survivors. And there have also been some studies of family knowledge, stress, social support, et cetera. But there have been no studies that have targeted the health system or the payer. So what that means is that if there are health system or payer level barriers to long-term follow-up care for childhood cancer survivors, we have not seen any studies that are targeting those levels of barriers. So after this report came out, we put together some supplement funding for cancer centers to do studies on organizational barriers to survivorship care for childhood cancer survivors. So when we're talking about organizational barriers, that's at that level where it said health system. And the idea is that there are barriers in how organizations are providing survivorship care that are inadvertently keeping survivors away from long-term follow-up at the cancer center. So these barriers include policies and procedures, culture, resources, teams, workflow, space, staffing expertise, and hours. So these are ways that organizations could be inadvertently contributing to barriers in long-term follow-up. And we funded 7 supplements, and I just wanted to give you the titles because I think this is really a first of all, we know that there are no studies of these types of barriers or targeting these types of barriers. And second of all, I feel that this is a very important area for us to be working. So from the University of Kentucky, we have a study examining rural-urban disparities in and predictors of childhood cancer survivors' organizational barriers. From NYU, adherence to NCCS and reproductive health guidelines. From Baylor, clinical benefit and cost efficacy of risk stratified survivorship navigation to overcome structural barriers. And from Georgetown, organizational assessment to eliminate outcome disparities among childhood cancer survivors. At Emory, improving support for survivors engaged in transition. From Johns Hopkins, improving compliance with standard of care recommendations for neuropsychological assessment. And from the University of Texas MD Anderson, we see a study examining barriers that drive disparities in equity in the delivery of occupational and physical therapy. The next topic I want to shift to is about primary care. And I don't have a lot to present, as this is an area that we are just starting to work on from the office, but I want to highlight something that happened earlier this year, which was an NCI roundtable on cancer prevention in primary care. We have formed a primary care working group in the Division of Cancer Control and Population Sciences that is in collaboration with the Division of Cancer Prevention at NCI. And we're talking about challenges in survivor care delivery, transition, and communication. So what do I think is missing and what is next for the office? And I want to go back to those original slides when we talked about how the office was formed and why. And I really see survivor cohort studies as the future of survivorship research. And I was very happy, actually soon before I arrived at NCI, there was a funding announcement on new survivorship cohorts, and there were 4 that were funded. They focus on minority populations, rare cancers, and survivors who've gotten immune checkpoint inhibitors. And there is also a ton of work that's going on investigating individual response to treatment. Sometimes this is called responsomics. There is also individual response to individual variation in toxicity, which is probably related to interactions between genetics and the environment and the treatment. And that's a huge area of research across NCI that I'm involved in. I also think we need to continue pursuing understudied toxicities. And for me, there are a long list of what I consider understudied toxicities. And I know that there are many people who are interested in these topics. We need to support technology and innovation. And we need to be asking what more could we be doing in disparities? And I really think those cancer center supplements are just the tip of the iceberg. The last thing I want to mention is an upcoming meeting on cancer-related emergency and urgent care. This problem of cancer survivors showing up in community emergency rooms or urgent cares is a huge challenge. It's a challenge that demonstrates the failures and inequities in our health system in the United States. And I think this meeting is going to be really amazing. So I just want to point it out to you guys. I hope to see you there. The problem of survivors in emergency rooms and urgent care centers is one that I have heard from actually a few different places that I have visited over the last year. And primarily where there is a cancer center delivering care, and then there is a community hospital where the survivor goes for some urgent need. And the fact that there is no communication or very little communication between the cancer center and the community hospital or emergency room or urgent care center is a huge gap and a big challenge, and something I really want to see us doing research on. And I just want to close with some words from my boss, Ned Sharpless, who, in celebrating the 50th anniversary of the National Cancer Act, has called on us to end cancer as we know it. And here's his words. What are we working toward? If we're building a bridge to the future of cancer, what's on the other side of that bridge? A world where we will have changed cancer as we know it. And I think that future is within our reach. Let's focus on a future where all people with cancer have the support and resources needed to navigate their care. Thank you.
Thank you very much, Emily. That was wonderful. I really love the quotes that you started with. We use that quote from Dr. Mullen, who was one of our founders, a lot. And I wasn't familiar with the other quote, so I really like that. And I appreciate you grounding us with that and talking about what you're doing. You mentioned that emergency department workshop, and I'm moderating a panel of patients talking about their experience, survivors. And we had a prep call and some really huge gaps in care, huge gaps in coordination of care when it comes to the emergency room. So we are looking forward to that meeting. And what I really appreciate is with that and some other, like the metastatic meeting that you hosted last year, when you're setting research priorities, you're including patients and advocates in the discussions and talking about what's important to them and listening to their experiences to help set the research priorities. And I really appreciate that.
Thank you for saying that. Thank you for saying that.
Well, I have a lot of questions for you. I mean, so I had already a lot prepared, but then I have more from the discussion. One thing before we start, I want to just talk a little bit. Thank you for mentioning the definition of survivor, because we also celebrated, NCCS celebrated our 35th anniversary of the founding of NCCS last month. And when our founders got together and really debated the discussion and discussed that term, it was really important to consider people a survivor from diagnosis. And we conduct our annual State of Cancer Survivorship survey, including, we conducted it this year, and we asked the question about, do you identify with the term survivor? And 85% of the people in that national sample, which is, really a cross-section of survivors, and we set quotas to make sure that it really does represent kind of the population of cancer survivors in the country. They're not connected to NCCS or an advocacy group. 85% of them identified with that term. And notably, 63% of people still in treatment identify with the term, and 93% of people 10 years out. So that just tells me that while I agree 100% with what you said about, not everybody does, and that's totally fine. And the research will still focus on the needs of people living with long-term cancer, whether they like that word or not, and whether they identify with it. But it does show that, it has taken hold, their vision 35 years ago, because this is the general public. This is not, it was even higher when we surveyed the people who are connected to NCCS and who have, found us as an advocacy organization. But when you're talking about the general public, most of those people really aren't connected to any of our patient advocacy organizations, but yet I think it's just become part of the lexicon. So I think, we agree with you. Everybody should identify how they want. But I was pleased to see that, really, especially the percentage of people still in treatment, because you do hear people say, well, I'm not done with treatment yet, I don't count as a survivor. But more than 63% did. And I was pretty impressed with that.
I really appreciate that you guys did that work, because it is important. We hear a lot of criticism about that word survivor, and maybe the answer is that, there will always be people who don't identify that with that word. It does have like that warrior kind of connotation or association. So there will always be people who just don't identify with that word. But at the same time, it may be some unfair criticism on the part of people who are saying it's not a good word, because, as you say, so many people identify with it. Mm-hmm. So we're here, we're sticking with it. And I'm very glad to hear that so many people identify with that. That's encouraging.
Yeah. So looking back over the 25 years since the office created, what do you see as the biggest gains in our understanding of the needs of cancer survivors following treatment, and how we deliver survivorship care in this country?
I think the biggest gains have been first of all, in the recognition and the acknowledgement of this population, and those words from Dr. Mullen about feeling left on the side to cough and sputter, I think we can respond to survivors and say that's just not the case anymore. You have so much attention and work and investigators and advocates who are paying attention to the person who's been diagnosed with cancer. For me, I think the biggest research accomplishment is the attention and the description of late and long-term effects of cancer treatment, the outcomes, psychosocial, physical, functional, financial. And I think that has been the major accomplishment. I will also say the work on identifying challenges in care coordination and for cancer caregivers, there have been some real successes there as well.
And where are the areas that we still need to improve?
Well, I have a short list of areas where I would like to see immediate attention. I think if we think of all of the gaps, we would go back to that portfolio analysis and the 2019 meeting. There are a long number of gaps and areas that need attention. But the top of the list for me, I think the causes and consequences of childhood cancer, those special populations like survivors of AYA cancer and older adults with cancer. And I would include in that the people who are living with cancer or the metastatic and advanced cancer survivors. I think survivors of new therapies. So as I mentioned, as we have success in oncology and in treating cancer, we need to establish how we're going to research late and long-term effects from new therapies. Mm-hmm. And the work that we need to do in disparities, in structural inequalities, I think we're really just starting that work right now.
Mm-hmm. Okay, so we were really honored to have you join us last year for the Roundtable when you were relatively new in the position. So now you have a little more than a year. So what is your vision for the office and what you hope to accomplish with it?
I know I've mentioned this to you before, Shelley, which I really think this office is the place for investigators and survivors and advocates to interface with each other and with the NCI as the funding organization, and that the office is a place where we can come together and collaborate and also talk about issues that have not been discussed before. As you mentioned, we're really trying to get the input of advocates in creating the agenda that we're setting. And I think that is what the office is here for. That's how I see it. Great,
wonderful. We love to hear that. And I love that your cat is joining us. So on a personal level, how did you decide to focus your research and practice on cancer survivorship? And you still see patients, right?
Yes. Yeah. This question is so hard for me to answer because I really get emotional in thinking about my career and the work that I do. But I will just say, and this is something I say to my kids as well, you have to find something that's meaningful to you. And this job is meaningful to me. This work is meaningful to me. And I could not have been luckier to end up where I ended up. And I am just extremely grateful.
Well, you're getting me choked up. And I always say, I tell my staff too, that if we get to the point where we don't get choked up talking about this, then we're jaded and we need to hang it up. So it is because this is people's lives. I mean, the whole point of survivorship is so that people live well with cancer and after cancer. And so, it's people's lives, it's people's stories. And so, yeah, it's an emotional topic. Well, I'm glad you're there because I think that means that you care a lot and that you're always going to make sure that patients are at the heart of that. Yes. So since you mentioned the Lost in Transition report, so since the publication, since cancer survivorship experts have focused on strategies for improving transitions in care that survivors experience. And I know that's something important to you since you focus a lot on care coordination. Yet when we survey cancer survivors in our state of survivorship survey, they say that the difficulty of being lost really begins even before that transition from active treatment to post-treatment survivorship. And they have serious obstacles to receiving help in managing side effects of cancer care and treatment. And they talk about the gaps in their mental health, treatment for their mental health. So how have the programs and grants and awards and other activities of the office help adapted to address the gaps in supportive care during treatment?
Wow, great question. So, honestly, I think in this country in general, we do not do enough to support mental health. And that's across the board. We don't have enough providers. We don't have an easy way to access them. And we don't have proper insurance coverage for many people for that type of care. The other thing I will say is this may be one area where the changes that have occurred as a result of the pandemic have been beneficial, because we've seen that mental health care and psychosocial support has really broadened its reach by adapting and utilizing telehealth and other distance interventions. I would love to see more work in this area. We have a funding mechanism that is utilizing information technology for depression treatment. And in cancer survivors, actually it applies across the board, but I think this is an area where technology could really do more for cancer survivors and their families. And I would love to see more studies along those lines.
Great, well, thank you. So you mentioned a priority being people living with cancer, with metastatic and advanced cancer. And I know that you hosted a meeting last year, which you mentioned, to really kind of help set those priorities. So tell us a little bit about what you learned about the survivorship needs of people living with metastatic cancer and how that's influencing your work and your funding opportunities.
Wow, what we learned at that meeting could fill a book. I would say there are some challenges in survivorship research in that population. To me, the number one challenge is that you have to constantly explain what you mean by survivorship research. And there are many people, including very successful researchers in oncology and leaders, who will say that this population does not need survivorship research. And so what that meeting accomplished is brought attention to a population that has needs with regards to managing toxicities, care coordination, long-term follow-up for recurrence or new malignancies. What we think of as survivorship care is really missing for that population. So what we've done after that meeting, and I believe the paper is in press, we went through each of those topic areas that we covered in the meeting. So it was health behaviors, surveillance, and talked about what is really needed in each of those topic areas. There are a lot of challenges, and there might be different solutions depending on the challenge. So one of the big issues that came out is that we have difficulty counting the number of people who are living with cancer. It's a difficult thing to count. It's somewhat easier to count people who've been diagnosed with advanced or metastatic cancer. But if you are diagnosed with early stage disease and then you progress, it's actually quite a difficult thing to capture for most cancers. Mm-hmm. And so that is a huge area where we need a lot of research. I also think, the list goes on and on. It's so long. From our perspective, we have the meeting, we publish a paper, and then we start talking about where do we need money and how should it be directed. So are we going to do a contract? Are we going to do some funding announcements? Are we going to put out a special issue? And there may be different strategies for different areas, but there's definitely more to come. I will just say that.
That's great. Sometimes it's just really frustrating how we get so bogged down in some of the terminology. And, we hear from survivors all the time that people living with metastatic cancer, that they are excluded from programs that are offered because they are not post-treatment survivors. And I know you can't do this, but I think that the NCI should consider if they are funding, that their NCI funded cancer centers should not exclude people living with metastatic cancer from their survivorship programs. A few years ago when ASCO hosted their palliative and supportive care meeting, Dr. Patty Gans, who was also one of NCCS founders, gave a talk that said survivorship care, the title was Survivorship Care is Palliative Care. I mean, we just get so bogged down in these semantics, but it's really just helping address people's quality of life, whether they're in treatment or out of treatment, helping them deal with the effects of cancer on their life, whether it's physical, emotional, and or financial, all of the effects of it. And we shouldn't have all these semantic barriers that cause us to not give people what they need to help them deal with these challenges that are a result of their cancer.
I agree 100%. It's
very frustrating.
Yes.
And I think also, that goes to like the semantics of palliative care that still turn people off from getting it. What if we didn't call it that? What if we called it? I know those are other discussions that happen, but if you just talked about it as supportive care, and I know some centers are calling it that instead of palliative care because people still equate palliative care with hospice. We know that's not true, but as long as the end users who might benefit from it don't think that they need it, then they're not going to get the benefit of it. What if we could call it something that is more welcoming to them? But I know that there are people who are vehemently opposed to that. But I mean, the point is that people aren't getting what they need and they're suffering more than they should because we're so worried about stupid terminology.
I totally agree. I agree. I will also say that the messages that NCI, NIH leadership, and that Congress get about what survivors want and need are meaningful. Mm-hmm. Because every time something comes through from a member of Congress or a leadership in the NIH, then they're looking to our office to say, what are you doing here? How should we respond to this? What's needed? What's missing? And so that work that you all are doing is very, very meaningful. It really makes a difference because we're not done. There is so much more. And you could go back to those words 40 years ago. Dan DiAngio wrote that paper 36 years ago, Dr. Mullen. And yet those words are so true. They are so true. We really have, a lot more work to do, I think. But it's exciting and energizing. I don't feel discouraged by that at all.
I get a little discouraged, but I'm glad that, I just get frustrated, I guess, let's just say. But it's good to have people like you that are there pushing for these important issues. So I know that primary care is integral to survivorship care, and your training in internal medicine gives you, an important perspective on that and understanding of primary care and how it can work better with oncology to serve cancer survivors. And we hear some say that primary care physicians are overwhelmed, they don't have time to learn and what it takes to provide survivorship care. Others say that they're willing and eager to take care of cancer patients. So what is your view on the role of primary care in providing survivorship care, and how do we ensure primary care providers understand what cancer survivors need?
That is a great question. I think both things are true, that primary care providers are overwhelmed. They are very busy. They are even more in crisis since COVID happened. And yet they are also very willing to take care of cancer survivors. And what I see from what researchers are showing us in survivorship research is that primary care providers want actionable information. So it may be less important to say, this is a woman who got mantle radiation, than to say, this is a woman who needs an annual mammogram and breast MRI. And she also had a splenectomy. So if she has a fever, you have to make sure she gets broad spectrum antibiotics. And to focus on the actions. And also to say, I won't be ordering her mammogram. That's your responsibility, primary care. So where are the actionable items? Where is the responsibility? And with those types of tools, that type of information, then the primary care provider is totally capable, willing and eager, able to manage patients. I mean, honestly, I don't think cancer survivors are more complicated than older adults with diabetes, hypertension, and hyperlipidemia. I just don't think they're more complicated than that. It's really just a matter of knowing. So, for example, when I was in primary care, I knew every time I saw someone with diabetes, I had to make sure, have they seen an ophthalmologist? Do they have peripheral neuropathy? Have they had a recent hemoglobin A1C? There's a checklist, and it's the same with survivors, but you just have to make sure that the primary care is getting what they need to deliver that care, but they are most certainly willing and able.
And so how are they supposed to get that, what they need?
Oh, I know. So, okay, well, there is some pretty good work on what we need, and the next step is really how to do it. So I agree with you. I think that's where the research needs to be. We have a big problem in our electronic medical record, approach in this country, where every institution is in complete isolation from every other institution with regards to medical record solutions. So, we have to figure out a way to do better with that. I will also say, and this is something that I've been saying for a little while now, we cannot rely on the cancer survivor to be responsible for making sure that they get high quality care. It is not their responsibility. It is our responsibility as providers. And asking a survivor to come in with what they need, what the other doctor said, what's on the to-do list, that's not acceptable.
Agree completely. And when we did in our survey, we have asked the question, basically people give their providers very high remarks, even when the care that they're describing is objectively not good care, and including saying that their care is coordinated. And we've asked this question the last 2 years. So this year we thought, okay, we know the care is not actually as coordinated as people are rating it. So we asked, a follow-up question was, how often do you have to be the one are you bringing information from one doctor to another? It was very high. That is not the only definition of coordinated care, but it is one measure of, if you, the patient, are the one that's bringing information between doctors, that's not well coordinated care in my view. But so they want to rate their providers highly because they're alive, and they appreciate that these people have saved their lives. So they're not going to give them a poor review. But if you ask them, did you have to be the one to coordinate care? Yes, they do. And we hear that from survivors all the time. They carry a binder of all of their information. They're the ones who's telling each doctor what they need to know from the others, because there isn't that coordination.
Yeah.
Okay, so the quality of survivorship care depends on where you go, not necessarily dependent on the size of the cancer center. There are some large cancer centers that have amazing survivorship programs, while others don't. Some smaller community cancer centers or practices offer survivorship programs, while others don't. I know that nothing is uniform, but how do we get to a situation where there's more equity in the survivorship care available to survivors, and it doesn't depend on, where you go for your care?
This is a big challenge and opportunity and focus for the office. Why is survivorship care delivered differently in different settings and for different populations, different types of cancer survivors? And as a focus of the research, absolutely, we need to make sure that every survivor has access to and can access and is able to receive high quality survivorship care. It's a huge priority. We know that there are these organizational barriers that I mentioned. Some of those are so simple. If you require people to come back on 2 different days for testing, that's an organizational barrier to long-term follow-up care that could be easily eliminated. So those are the kinds of things that we're seeing through that Cancer Center supplement announcement, but there is clearly a lot more work to be done here.
So you mentioned that the Childhood Cancer STAR Act, which was passed in 2018, and the studies related to survivorship and some of the funding supplements on organizational barriers. So are there other noteworthy findings from the studies that ARC did, and how have they informed your funding and other efforts?
So those next two reports are still coming out. I think one had an opportunity for public comment, and now it will be released shortly. What I will say, what we know, what we saw from those two reports is that there's just very little research. And in fact, the transitions report includes all children with all different types of chronic diseases, because there were no studies in childhood cancer on transitions, no interventions to facilitate transitions, no randomized controlled trials. So that is an area where it's almost impossible to review the evidence because there's so little evidence out there. So we just have to say, well, we just need more information on what is keeping survivors from childhood cancer survivors from transitioning to adult-oriented care.
Okay. So you also mentioned implementation science. So can you talk a little bit, just first of all, tell us what does that mean, and then how can that help with the uptake of what we've learned from research about survivors? Because I think sometimes there's that disconnect between what we know and what happens in practice. And I know that's where implementation science comes in, but can you talk a little bit more about that?
Absolutely. Implementation science is when you take evidence from clinical trials or randomized controlled trials and you figure out how to deliver it, how to disseminate it, how to implement it. And in some cases, you're testing different strategies. For example, we have lots of interventions to help people quit smoking. We also have lung cancer screening, where at times current smokers are coming in for CAT scans to detect early lung cancers. That's the idea. So that's an opportunity where you could deliver, you have a smoker, a person who smokes, who's coming in for lung cancer screening. You could deliver tobacco cessation in that setting. But what we've discovered is that a negative scan in that setting makes people less likely to quit smoking. So how are you going to adapt your tobacco cessation intervention for that scenario? And that is implementation science. And there's a few ways that we're working in survivorship to try to leverage implementation science opportunities. One is that I will say, if you go to our website, you can see evidence-based survivor interventions, things like caregiver coping, diet and physical activity that have been tested and shown to be beneficial in survivor settings, but maybe have not been disseminated or have challenges in implementation. And that would be an area where we would like to see research.
Great. So you mentioned research conferences and how important they are. And I know that the biennial that was being hosted is no longer happening, and ASCO is no longer offering their survivorship conference. And there was a great conference this year for Cancer Center Survivorship Research Conference, which I believe is going to happen again in 2 years. But, talk a little bit more about why they're important, and what is this Cancer Center conference sufficient to sort of fill the gap to help make sure that we're sort of stimulating the right research and sharing information about the research and sharing the findings of the research?
So I do not think that the Cancer Center Research Forum is sufficient, but it is certainly helpful. And one of the lessons, I think, of the pandemic is that we really do need opportunities to meet in person to discuss research findings and generate new ideas and to establish collaborations. And if it's not a survivorship meeting in person dedicated to survivorship, then we need to find other ways to do that. And from my perspective, I have a few things that I think OCS can do to facilitate collaboration and generate scientific cross-pollination. One of them is that next week we have new investigators in cancer control and population science. Newly funded investigators are coming together for what we call the new R01 meeting. And there are over 50 of these investigators who are coming together virtually for this meeting. And during that meeting, we're having a smaller meeting, which is survivorship investigators. So this would be newly funded investigators who are doing survivorship research. And my plan is to take that little crew and turn them into the class of 21. And we're going to meet regularly and share our research ideas. And I have a whole series of senior investigators who are going to be speaking to this group. And I really hope to help them build an identity in survivorship research and also build friendships where they're inviting each other to give talks and sharing opportunities on scientific manuscripts and things like that. So that's one place. And it's really just one of many, many ideas for that I have about how we can try to bring investigators together and support them in these scientific collaborations. The science of survivorship is a multidisciplinary science. And so we aren't coming together at those professional organization meetings in the same way as other fields. So we do need to really, really find ways to support investigators. I would love to see a survivorship research meeting. Again, a really cross-cutting, wide open, inexpensive, centrally located meeting. I would love to see that. I hope we get there.
I hope so too. Well, maybe we can work on that together.
Okay.
Thank you so much for joining us. Thank you for your time and your leadership and your vision and your commitment to patients. We really appreciate it. And we look forward to continuing to work with you going forward.
Thank you. Thank you so much. Thanks for having me.